she's approaching second stage of labor. When she came, she was having mild contractions, but the contractions are accumulating. So she's approaching the second stage of labor. We are expecting the delivery this afternoon. That is if the cervix takes up well. It also depends with the cervix, the dilatation of the cervix. That is the one that lets the baby come out. So if it takes up well, we are expecting a delivery in the afternoon. Jaribu kutembea. Kwanza kutembea inakusaidia sana. Shuka tu.
Fikisha hivi hapa jioni.
Hapana. Mtu afikisha jioni. Unaendelea vizuri. Tazatu. Shuka chini tembea.
Mwenye atusingi mama yake ni mjinga sana.
Tembea mtoto anashuka chini.
The maternal mortality rate is extremely high in Kenya. It hasn't really shown any improvement since the last census. It was around 488 deaths per 100,000 deliveries. That is absolutely unacceptable. And the basic causes of death are three issues. It is access, physical access, financial access. People do not afford maternity services. And the third one is social and cultural beliefs. A lot of people do not come to our facilities to deliver.
It's a situation that essentially means some portion of pregnant mothers in a population are lost to death. For every woman that's lost in death, there are another 10 who are injured in some sort of morbidity as a result of the inadequate access to these services.
Reproductive health is very critical because it has a bearing in all sectors. When you have to think about development in the wide perspective, you always must consider issues of human resource, and therefore reproductive health becomes very central in that.
The Reproductive Health Voucher Program is a simple mechanism to bring healthcare services to women and men who are traditionally excluded or unable to access healthcare.
We have an overall weakness of the health system in giving family planning services, but also other services of reproductive health, for example, skilled attendance delivery, to the poor part of the population. So there was a huge problem of access, how to access the health structure when I'm a poor Kenyan. Normally I have to pay then out of my pocket for all services. I can't afford it. And that's why we thought, okay, what could be now a new approach to improve access of poor Kenyans to health facilities?
OBA stands for output-based approach. This is a healthcare financing model that allows donor funds to be directed towards specific outputs. So unlike other models of aid, we pay for services that have been rendered and not for inputs as the previous models existed. The reason why the output-based aid approach is being piloted in this area is because it's been seen that the input-based aid approach does not necessarily result to improvement in quality of services.
So the whole idea is that we are able to see the results both at the facility level and within the community. We also see the output in terms of the goals that we have set forth, which is safe motherhood and family planning, and also dealing with gender violence and recovery.
Yes. Yeah. Hii kwanza tuanze na hii ambayo inaitwa kadi ya uzahaji. Sawa sawa. Kadi ya uzahaji. Si mnaiona? ukiangalia ndani imechorwa picha ya mama ambaye ni mjamzito. Sawa sawa. Hiyo ndio ile tunasema huduma ya uzazi. Sawa sawa. So unaona ni picha ya mama ambaye ni mjamzito. Sawa sawa. Yes. Kumaanisha inashughulikia yule mama ambaye katika ile hali ya ujauzito mpaka ajifungue. Sawa sawa. Ukiangalia mzuri imegawanywa mara tatu. Kuna hii part ya kwanza ambayo inaitwa the ANC copy.
A low-income household, a woman living in poverty here in Nairobi, is faced with a significant barrier to care. Her monthly income, she may be making $50, $60, $70 per month. She might be facing a delivery cost for a normal delivery, assuming everything goes well. She might pay 4,000 or 5,000 shillings, about $40 or $50. That is a significant amount of money, and that's assuming that everything goes well. She may, in fact, be faced with the need for a C-section, in which case she'd have to pay 20,000, 25,000, maybe 30,000 shillings out of pocket, $200 or $300. The amount of money that she's paying out of pocket is significant. It could be 2 or 3 months worth of her income. Her household may not be able to afford that, and she's then calling upon relatives and others to contribute for delivery where even the survival of the child is not certain.
Lakini siku hizi akaenda jabali kwa meniambia kungeti kaze nitafute tu pesa na nikupeleke nini kupeleke usiku. Saizi hata akisema atapiga wazazi wake saizi wanamuitisha dogo wanamwambia tutumie nini pesa. Sasa ndio nilikuwa naambia utajikaza tu utafute kazi, ukipata kazi tukipata utaenda usiku. Tena nitaangalia kama watu wetu nao watanisaidia tu kitu kidogo. Tujaribu kazi tuenipata. Sasa ndio alikuja kaniambia kuna unafaa uende uchukue wote itakusaidia.
My husband alikuwa jobless, so sikuwa na pesa. Then wakati nilikuwa ninaenda clinic na Sareb, walikuwa wananiambia watanioperate, so tunifanya CS. So nilikuwa ninaambiwa nilikuwa ninajua nitatoa pesa mingi, but I thank God because of Voucher. So imenisaidia first baby and then the second baby.
I had one client, she was very poor, really poor. You know those clients who, even at yourself you can tell, even if you have not interviewed, you can tell she is poor. And she had to undergo a CS, she had twins. So when I told her which facility to go, she went and she was referred to the big hospital, which was Kenyatta. And they served her very well, and I was very happy with that, because for sure I feel like I helped her. Yeah.
Were there any specific challenges you faced this week that are, we start with the ones that are unique to the week? We talked about the weather. Mary?
I think nothing specific is, apart from clients who are brought by their relatives. Those are some of the challenges we meet when we notice that these clients are not from Korokocho. They stay somewhere else, and their relatives are bringing them to take the vouchers.
So when you go to their house, it is not theirs. They have already, they go to the house, and then when you ask them about the house, they don't know anything.
Anything in that house. So that clearly tells you
she's not from that area.
Yeah. Okay. I'm sure that would also mean we are doing a lot of sensitization.
Yes.
Yeah. So that's a plus on our side. It's just the idea of how to deal with such issues. Cindy. But the good thing is you just explain to them well how the program is designed, and that is specific to Viwandani and Korogosho.
I think a big impact is to try and educate patients and about getting better care, better services and all the rest of it, and bringing them back into the facilities to deliver. I think that's been a really a huge success story in itself.
Kuna stima?
Hakuna stima.
Iko na maji na choo?
Hapana, tunanunua tu, hata choo ni kulipa.
Choo unalipa?
tunaenda tu na pesa.
Takataka mnajitupia ama kuna mtu anaokota mnalipa?
Tunarushanga kwa mtaro hiyo ya nyuma. Hiyo maji yanateremka kule.
Facilities do benefit from the program in a variety of ways. Being accredited to be part of the program provides some sense of status in comparison to our facilities. And some of the facilities have used the reimbursement for improving the MCH, Maternal and Child Health Unit, paint the wards, improve basic elements like curtains in the wards, which is something that everybody will look at and say, wow, has improved, and that already feeds back to that sense of motivation and elevation of their status.
You know, when we started here, we started it as an outpatient clinic. The demand is the one that dictated that we established the inpatient, whereby we could also do delivery services. Because we also hired new staff, and we even now can afford to pay them a better salary. So all this is kind of motivating, and the response from the patient is quite encouraging because they really enjoy the service.
The voucher allowed the service providers to invest in quality and in capacity. So each and every voucher client coming into a hospital represents for them an additional source of income. And this is especially important for public hospitals because they are chronically underfunded and they can't afford to implement all the waivers or free fee services which they should do. So they have a lot of clients which are not able to pay.
For sure, the program has really improved our facility in that it was now really attracting so many clients to come in. Before, the facility was not very clean, but through that OBM money, we managed hiring 2 casuals who are ensuring that the environment is very clean and attractive. And again, for the OBM money, we have used it in decorating our rooms. Each and every room, we have the curtains. So when a mother comes, the privacy is being maintained. All the rooms with curtains, all our MCH is having the blue curtains. This is OBM money. So we have used the OBM money for buying this. This is the heater we have used because majorly when a mother delivers, she's always becoming so cold, and we thought it wise for us to have these heaters. It's ideally as in the maternity, we should have this.
One year, I think 40% bought the voucher and did not use it because of the issues around transport and going into labour at night. In other countries, the vouchers cover the transport for the woman to get to hospital, and that doesn't happen here, and I think that would be an important solution. The Nairobi facilities are a bit different because there's only these 2 informal settlements where the vouchers are being sold, and there aren't that many facilities within. Well, I don't think there are any facilities within those informal settlements. They're kind of on the periphery. So a lot of people will probably go to the nearest one because they know it's accredited, but it might not be the best one.
When it comes to the urban settlements, the main challenges are the distribution of facilities, and also the fact that they are based in the urban areas where most of the health services costs are high.
You see the slum life. If you walk around, then you'll say the facilities are clean, even if they're not that clean. Because you see, like us, when we walk in the field, you meet with feces sometimes, those flying toilets, and you just step on a paper bag so. I mean, the environment is like that. So when they go to a facility and they don't see such things and, there are no flies, you'll say they're clean, yeah? So most of them say the facilities are clean. The complaints you'll hear them complaining about are not about the dirtiness. Maybe it's just how they feel they were treated. Maybe they feel, oh, they took long to but cleanliness, super. They all say it's super.
So the clients will have to look for a way just to get to the facility. That's why you find even sometimes because of distance, you'll find some clients delivering in the house. Because maybe she went into labor at night, there's not even a taxi close by, and the baby comes, what do you do? These are some of the challenges, and that's why what we have done in this particular area, you can see the challenge is actually in the upper part. So what we've done is we've approached some government facilities that have come up in this space. They've been accredited as health centers by the government, so they have already written to the ministry and to VMA for accreditation for third phase, so that we can take services closer for these clients who don't have to travel very far.
Familia uchungu mami. Ai, ufanye uchungu hizi. Itaisha ukizaa. Kizaa na mtoto atoki. Pesa yake ya kutoka bado. Pesa yake nini? Naenda kubadilisha mimi niende. Oh baby. Mama yangu sijua hata mwili wangu sijua Haiko tu sawa, iko tu sawa. Tukavalishe nguo juu hii weather, sasa kanaanza kusneeze chip chip hivyo. Tukavalisha ka keep warm juu ya pia hata hiyo weight, and then tomorrow tutakaosha poa. Baridi. Lazima umalize kazi zake zote. Ndio kwa bomu. Siwezi zaa. Umaliza.
The baby is okay. The baby is okay basically, but that was fetal distress. As you could see, there was meconium all around. That yellowish coloration means the baby was distressed. Ukija clinic hapa? Mimi kulikuwa unaenda wapi? Oh, Tigoni. Usikiaje baridi? Baridi mingi.
If she was to give birth at home, it wouldn't have been possible. She would have landed finally at an hospital, probably the baby died, because there was what we call CPD, cephalopelvic disproportion, and there was also, because of the time taken to deliver, she also developed, the baby developed fetal distress, and that's why you saw the green
yellow stuff.
Green stuff that came out when you opened the uterus. That is what
was a sign of distress.
That's a sign of distress. Yeah. So probably should have come to the hospital too late, but delivery at home was not possible.
Should be kept very, very warm. Dia hanini enda kome na mwana umogithie na ikire
lakini Mungu ni asante ya kunipe mwenye nilikuwa nataka.
Tatizo kama kijana na
siwezi pata wengine venye nimefikiri.
Kwani?
Hapana.
Ningepata wanne wasichana.
Hiyo ni wakati wa kina Madhi, lakini si wakati wetu. Siwezi, akitaka mwingine atatafuta na uko nje sasa. Lakini si mimi.
So mother, after the cesarean section, we usually keep the mother for 2 or 3 days just to observe any complication or anything how she's getting on. And today is the first post-operative day. And mother, blood pressure-wise, everything is okay. We are still putting the catheter, urine catheterized. So we'll check about that thing for a couple of days, and once she's okay, then she will be discharged on the 4th day.
Vouchers are not a panacea. They're not going to solve the many issues that the health sector confronts in East Africa or in South Asia. But vouchers provide a mechanism, a safety net, for low-income populations that otherwise have access to health care but simply can't afford it. So it provides a financial incentive to facilities to see these women, see them promptly, and gives women the wherewithal to demand services at a facility of their choosing.
So far, we have delivered about 100,000 babies through the vouchers. And we think it is one of the greatest programs we have had in in Kenya for improving maternity services.
Our staff now are able to interact with the provincial team, and they're able to hear very good positive stories that would come from clients who have benefited the program. But the enthusiasm is on every level of staff, and this is one project that brings in a lot of joy, and when you go back home, you know that at least you have helped to make somebody's life better, at least for good. Yeah.